It's such a wonderful Wagga day, and I came down on the train last night, but it's always good to come back here from Sydney. So look, yes, today's talk is on... Sorry, I'm just going to close this screen. Okie dokie. Okay, so we're looking at the medical aspects of substance use disorders. Now, when we were born, we didn't come with an operator's manual, but I'm hoping to, at least in some way, provide an operator's manual to the brain. I don't have any expertise in the brain itself. I'm just a humble GP, but obviously I see a lot of patients, and in the context of veterans care, it's very important. I have no conflicts of interest. Everything I can appreciate from what veterans go through comes from the stories my dad would tell, from his father who served in the Royal Australian Navy. The scrap iron flotilla went from Sydney to, or from England originally, then to Sydney, then to the Mediterranean, and in all manner of places serving. And in that time, you can imagine working shifts at all hours, being ready to move at a moment's notice, and the pressure that would put you under. And my dad said from his own dad, who was a leading seaman, he learnt the choicest swear words from his dad, who was a sailor, but also found that his dad had an issue with alcohol. So hopefully we can sort of lift the lid on why that would occur. And I think a good recommended reading, if we were to hone in on the cellular aspects at play here, would be something that was hosted by the Pro Patria Centre earlier in the year, which is the talk by Mark Gordon there. So another commitment that Pro Patria is setting to pushing the frontiers in order to get the right care for veterans. Today, I'd like to help you guys understand the disease model that we can apply to addiction, in the same way that we would look at hypertension or diabetes as a disease model. It has chronicity, it has relapse rates, it has a treatment plan. In the same way as we look at diabetes, we should look at addiction as applied to the disease model. And we'd like to have a look at, particularly on the brain, at how substance use and misuse affects the brain. And most importantly, I think, in order to position ourselves as people who care about treatment and the people we care, we do have to remove the stigma associated with substance misuse. Now let's look at where we are in the 21st century. We do have more stress, and certainly COVID proved that, and that's not just me thinking about it. The ABS showed that 15% of Australians aged 16 to 85 reported high or very high levels of psychological distress in 2020, 2021, and this rose 17%. So we've gone from 15% to 17%, and that highest burden is 26% amongst 16 to 24-year-olds. We're getting less sleep. We're less financially secure. We're not drinking more than we used to drink. We're pretty much drinking as much as we always did. At about 1/4 of us are drinking too much. We're always subject to traumas, whether emotional, psychological, head injuries, and those sorts of things. One thing that is characteristic of the 21st century is that we have less access to nutrient-dense whole foods. And that's certainly a problem if we're approaching a patient holistically. We do need to address the dietary deficiencies as well. And then we transplant that context to the very fine subset, which is our veteran population. So generally they're healthier than the average person, and whilst they're in the force, they're not abusing substances more than the average person. In fact, they're abusing it less. But what we know, especially from the Royal Commission into veteran suicide, is that after people left the forces, they were 21% more likely to commit suicide in males, and in the females had a higher burden at 81%. And this is all despite being in a healthier population. As I said, whilst in the forces, and there must be something protective about being a veteran, they're using substances less, and they're probably not drinking more than the average person. So let's have a look at the three things we need to survive: food, water, and not oxygen, dopamine. Okay, so think about, when you hear the word dopamine, just think about the word motivation. Okay, think of a mother bonding with her baby. Think about something when we do good that reinforces the good and we want to do better. Those are the things that make it possible for us to survive. It's actually possible to test this. You can deprive people from water, or you can deprive people of food, and then you put them in a functional MRI and see the territory of their brain that's occupied, that's salient or relevant for food or water seeking. All those dopamine areas light up. So dopamine is very much responsible for motivation. Now, we said part of the aspect of this talk is to remove stigma. Have a look at this article from the Sydney Morning Herald. You could have restless leg syndrome. You could have Parkinson's disease. You could be prescribed a drug by a GP or a neurologist that could make you have a gambling problem, something you've never had before. And the basis for some of these drugs, is certainly not first-line drugs, is dopamine agonists. They activate the dopamine receptor. So you can take somebody who's never had an issue with hypersexuality, overspending, gambling in this case, and you could turn somebody into someone who cannot control their motivations. This is an example of a court case that was, I think, settled out of court when Pfizer had to pay out many millions of dollars to about 200 people who said, well, you didn't put a warning on these drugs that they might cause me to do things I wouldn't ordinarily do. So this could happen to me. And let's not just talk about dopamine agonists, let's talk about opioids. Perhaps a bad habit of people, of doctors in emergency departments, is to prescribe opiates like endone, which are strong opioids for pain presentations. Now, if you have a quick look at how much opiate I might give you, the more, let's say in the first prescription I gave you access to 20 short-acting endone tablets, for example, then your risk of continuing that at 1 year is about 40 to 45%. And that's because opioids lock step with dopamine release in the brain. For some people, I don't really know myself, but for some people, it gives them a rush. And then 3 years later, half of those people are still continuing to use endone, maybe for reasons they never intended to use it for in the first place. And so you'll see that there's been a response to reduce the access to opiates, for example, in the community. You can't get codeine-containing preparations, for example, without a prescription. And this is a public health response in recognition of the fact that it is easy for ordinary people to get addicted. So let's have a look at addiction defined. It's a primary chronic disease of the brain involving reward, motivation, and memory. So you think about the things that you like to do, there's a strong memory component attached to it. And it becomes pathological when you're pursuing reward and seeking relief. So a lot of what we're seeing perhaps is symptomatic of all the things we spoke about, the assaults on the brain. People gravitating towards substances in some case is symptomatic of a self-soothing mechanism. Going on, we have an inability to abstain, that's in red, because we're trying to put off the negative features, and we have reduced insight into the fact that it's causing a problem, and that's why so much of perhaps people that we know their behaviour is inexplicable, and it's characterised by a cycle of relapse and remission. Now, So DSM-4 has developed into DSM-5. Basically, there's less criterion to be diagnosed with a substance misuse disorder, but basically hazardous use and then development of withdrawal tolerance and the opportunity costs you have. Let's have a quick look at alcohol. Alcohol featured 57% of the time in drug-related hospitalizations and deaths as well. And a lot of these were accidental. Alcohol being the most available drug, it also features more heavily. Now, this is a breakdown of all the people who had self-inflicting injuries and suicide in 2019. And I wanted to highlight, sadly, child abuse and neglect features most strongly in males and females, but look at all the other ones for males. Illicit drug use, alcohol use, cocaine use, amphetamine use, opioid use. All of these feature heavily in cases that involve suicide. So if our veterans are more likely to hurt themselves after leaving the force, then we must be talking about substances and substance misuse because they feature very heavily. And it's no different, unfortunately, for the ladies. There is good news afoot, however. If we look at the green bar here, we do see a downtrend since 2019 in drug-related deaths. And I think perhaps most steeply is the opioid-related deaths. And I think this reflects the less access we have to opioids in the community without a prescription, and that's a public health response, but also the fact that we have reduced quantities available. So that's a good protective feature. Now, we've often very permissive about the use of cigarettes when we're trying to help people detox. We say, well, look, we'll look after their heroin, don't worry about the fact that they smoke. But what we found is that if you do smoke, you've habituated short-circuiting of your pleasure circuit. So if you're doing that with nicotine, you can also do that with other substances. So we find that we can reduce your quit rate, your abstinence rate, if we also address your cigarette consumption. So I guess this highlights the fact that we ought to be holistic in our approach to healthcare, and I think Pro Patria will be very successful in that because they do approach a whole person model of care. Now, I did say we're going to have a look at the operator's manual. Let's think about the brain as a hierarchical structure. So at the top we have the cortex, that's the grey matter, that's where all the thinking and executive function happens. And as we get lower down, we get to the workhorses, but perhaps those are things about which we're not perfectly conscious. Now, most people would know right at the bottom we've got the amygdala, which is where flight or fight is often seen, and it's not very high resolution, it's a low resolution response. You see a spider coming towards you out of the corner of your eye and you have a stress response, but that's closely linked to the hippocampus. But what I want to draw your attention to is the ventral tegmental area, which is closely related to this striatal nigrostriatal area, which projects to the midbrain for Parkinson's management. But the ventral tegmental area is basically the seat of motivation and reward, and that projects via a few pathways, via the yellow to the executive function, planning, thinking, motivation, but also to the pleasure centers in nucleus accumbens. And this is where dopamine is largely stored and released into. But consider also that when we get into thinking about how it is that addiction develops. So we're not just talking about the anatomy now we're talking about pathology. First, you have to be exposed to the substance, so you have binge intoxication. And that happens at the level of the basal ganglia, as I said, the lower part of the brain, the part about which we may not have perfect conscious control. And then we get withdrawal or negative effects, so we start seeking the drug again, and that makes us feel stressed, and that projects into our prefrontal cortex when we start planning, I've got to have my next hit, and that can become overwhelming. It can really overtake all of our energy. Now, over time, you will know that the more you use the substance, you get diminishing returns. So as the substance use disorder continues, the positive reinforcement starts to fall away. The motivation's still very strong, but the motivation is carried by negative reinforcement. Think about that glass of water in the desert. There isn't anything you would do for that glass of water in the desert, if only it could keep you alive. And this is all salience model, that which is salient to you. So if you've become in the grips of substance misuse, sometimes that's the only thing that matters. And I want to illustrate that with this point. Someone, I don't know how, worked out a quantitative way of looking at dopamine. So just think of your normal day. You had to get up, you had to come here. Your dopamine level for your motivation was probably sitting about 50. Think about a day when you've had the flu. Maybe your dopamine level is about 40. You can't really get out of the house. It's hard to leave. You want to walk around in your pajamas. And then think about the best day. You catch a, 20 kilo trout. You get married, you win the lottery, and you catch the overnight train here to Wagga. Best day ever. This is sort of the range that we operate in the human brain, somewhere between 40 and 100. Your favourite food is actually quite important in dopamine release as well, so that's important. What can I say? But let's hijack the brain now. Let's look at methamphetamine. Methamphetamine will give you an 11-fold increase in the amount of dopamine that hits your brain and your neural circuits in a very short period of time. The brain does not know how to operate at this level. And suddenly, what you've done is you've flooded the brain with chemicals, and it's obviously intensely pleasurable, but look what happens as you continue to do that. You're getting diminished returns, and there are mechanisms underlying exactly how that happens. But by about the 5th use, you're at 50 again. So now you have to use methamphetamine or whatever it might be just to feel normal. And so it becomes all-encompassing. And it doesn't have to be methamphetamine. Other stimulants like cocaine can cause, over time, a lack of dopamine 2 receptors in the brain. So there is a response to the brain, an adaptive response to protect itself from the exposure to too much chemical, such that it downregulates those dopamine receptors so that we don't have a heart attack or a heart doesn't race or something like that every time we're exposed to the drug. So those adaptions hurt the brain, because now holding our child, going for a walk, playing chess with our son, whatever it is, it just doesn't feel right, doesn't feel normal. Nothing feels normal unless we have cocaine. I also wanted to have a quick look at all the stimulants that, all the all the chemicals that might lead to a release of dopamine into the nucleus accumbens: cannabinoids, opioids, alcohol, nicotine, alcohol, stimulants, and more opioids. And it's a well-known phenomena that we can downregulate the receptors through influx of calcium. Now, we learned in that other talk on neurobiology and neuroinflammation that calcium can be a bad guy. And it can lead to the invagination, or the drawing in of the receptor into the cell and making it the receptor density less, so that it also paves the way for a lot of the craving mechanisms and underlies the tolerance mechanisms that we have. Now, I was going to go on, but I might just leave it at this slide because I want to be treatment focused. I don't want to. I know we've got a short time. The principles of management are fairly well understood in this. Detox is important, but it doesn't predict for long-term abstinence. We also obviously need to treat the comorbid psychiatric disorders. If we're a bit ambivalent about whether 10 drinks a day is normal or not, we need to use motivational interviewing to line up where it fits with the rest of our life to remove that ambivalence and get us off the fence. Obviously, management needs to be tailored and customised to our patients. And we need to remain in treatment. So if I have a patient who's in the grips of this, I schedule a weekly appointment with them, so that I'm following them up. Even though it's not the best on telehealth, at least I'm getting, chipping away at their motivation and seeing where they're at. That's really important. Bringing in supportive cares and addressing neuroinflammation. And by that I mean looking at sleep, looking at the chemicals they're taking in, looking at nutrition. Look, I will leave it there because there's many other wonderful lineup of speakers, but thank you very much for the opportunity to speak to you today.